So thank you everyone for wonderful opening remarks and insights about your role and your perspective on data, AI, and the future opportunities. So one question I have for you to get started, and as a reminder, there is a microphone on this side. If you have any questions, please line up there. And to get us started, the question I have for the panel is, research is rare diseases heavily data-driven. But good quality data is not always available or accessible, like everyone pointed out, across all geographies. There is a lot of bias in the data. Over 90% of rare disease research is funding, and programs are US and EU based and focused. So how is this bias impacting research in your area of focus, in your programs? Paul, maybe we'll start off with you.
We collaborate with a lot of international institutions, and we fund some. The European data is very restrictive, and they don't typically like to share their data. We have a Harvard grant, which is working with Denmark, and the Danes are very, very tight with their data. And they're also working with the Finns as well, the Finnish. And so they're also a bit, when it comes to their data, they want to keep it in country. And I think that is a factor. And I think that when it comes to collaboration, especially cross collaboration, there needs to be more data which can be shared, across borders as well, because what's happening in a country, whether it's Europe or whether it's the US or whether it's India, I think it's very important to see exactly what's happening with that data. And if you can't see that data and analyze the data itself, there's going to be some holes and some gaps as well, which could be down the road, not good for everybody.
Sophia, you mentioned that 70% of your registry is non-ex-US or outside of US. 5% of the world's population is US, right? So 95% of the people in the world live outside of US. So it's still not, it's an exception already, great, but 95% would be the normal, right, to get the full global coverage. So what do you see from your, but congratulations on ensuring really 70% outside US is commendable. What are you doing differently? How are you achieving that?
So again, our registry is different from the others because it's patient driven, and we're a patient organization, and it's patient reported data. So we don't have to worry as much about the same necessarily like data privacy laws that have to do with clinical data, right? It's easier with patient reported data. But I think what we are doing really differently is that we are truly working with the entire community. Our organization, we share all our projects very publicly, and we always invite others to participate and collaborate. So when we started our registry, we had actually a big webinar. We invited everybody. We said that we're going to start a registry, and they said, if you want to be involved, let us know. But when they started to collect some data, we started to work in a paper. We actually, again, announced that we are going to be working on a paper. Do you want to co-author it with us? So this way we got a really great group of researchers, including international researchers, who also shared with their patients our registry. I think a lot of it comes down to just being open to working with everybody. We have international families who don't speak English. We communicate with them through Google Translate, but we never said that like we wouldn't be able to communicate with them. There's so many ways right now. There's so many technologies that you can communicate with everybody. And so we try to reach out to everyone. We have partner families. Every family is welcome to join us as a partner family and work with us and help us and help share in their own country, in their own language. We translate the registry to other languages. So it's all of it combined, but it comes down to collaboration and really reaching out and just really open communication with everybody.
Super good.
Harsha, I think it's an interesting point you bring up, which is, are we over-indexing on countries that actually have the resources to collect its data, right? So I want to apologize for everybody who runs registries, and this might sound trivial, but can we think of platforms? So if we think about how we address missing data in data science problems, we have that same problem here. We have missing data from a number of countries, and we have representation from maybe a few percentage of people who have this disease. So could we kind of think about, and maybe this is absolutely impossible, and my apologies for this, but I'm just thinking, maybe social media or Facebook or Twitter, where people are beginning to share information about either their symptoms, their conditions, drugs they're using, etc. It's not the level of detail of case report forms and hospital-based or population-based registries, but could there be at least some data from the 95% that we could start to learn from, and then maybe direct the policies to where we need to drill down a little bit more?
So one of the issues that happens, especially for a research-based registry, is there's certain IRB protocols have got to be formed. And if you don't have consent, you can't join the registry. So our registry, you can go ahead and join, consent, and so forth. If you go to social media, we do social media all the time in our registry to get the word out, to inform people about our publications and our initiatives and so forth. But we don't get any data from those particular platforms because there's no consent process and they're not technically a research platform. Another thing you bring up about social media, drug companies hate social media, especially on clinical trials, because when the biases occurs, am I on the placebo? Am I getting the real formulation and so forth? And so there could be issues when it comes to clinical trials. And we've heard a number of individuals, or just stories about ALS clinical trials out there. Did I get the placebo? Did I get the actual real drug? Hey, I feel better. And so there could be a bias that could be certainly introduced in some of these clinical trials out there.
Yeah.
I agree. The data is definitely messy, but could it give us some pointers?
Right. So it looks like, Sophia, you're having some success because of direct-to-patient approaches, reaching out to patient groups and such. So, Dr. Shukla, in India, what are you seeing the use of social media and or direct-to-patient strategies to increase the registry traction?
Yeah, while we were developing this registry, there were a lot of discussions and rounds of discussions on whether patients themselves should be allowed to register themselves into the registry. But like I earlier said, that the awareness of about rare diseases and how to diagnose them and identification of the clinical features of a particular disease, etc. They are really in the nascent stages. People are not aware of it, and if we allow people to self-report, there might be problems arising. Like I agree with Dr. Paul on this.
If I could just quickly mention, the Europeans have very robust registries, or registers as they call them, across the continent. But the Europeans have a different healthcare model. Ours is fragmented. In India, it's probably fragmented as well. And so because of that, the Europeans, because of their structure, can get a lot more data and a lot more granular data and comprehensive data as well than ourselves. And that's why there'll always be missing cases. Even in the European segment, there'll be missing cases too. But I think especially in areas which have that need or the capacity or the lack of resources, that's where those registries are very beneficial. But like what Dr. Shukla is saying, I think it's very important to point out the fact that, do you want a population of patients just coming in there and putting in data, and is the data any good? Because good data and bad data, are two different things. You can have good data and you can have bad data, and your data scientists can, go crazy trying to figure out exactly what to do with the data as well. So,
great insight. We have a question from Dr. Bhaskar.
Sure. This question is for Dr. Amleen. This is Dr. Bhaskar here. I think just want to, see, it gives me immense pleasure to actually see the progression from when Dr. Soumya Swaminathan and Dr. Rita and Dr. Madhulika, Harpreet, yourself were all part of this initial group of creating the registry. So, and it has come a long distance. So it is really nice and heartening to see 11,000 patients there. The question now is, what is, in your opinion, the way forward? Are we going to use, the forms that are there for the other institutes as well, where we can actually, get in more data? Can we use we just saw LSDs about 400 only. There should be 30,000. So are we looking at something which comes in from the others, from the patient bodies, etc.? Can we actually start training them on the forms, which is a little bit complicated, as I understand? So is that the way forward? Are we looking at using this data for policy shaping in order to drive the budget that can be allocated for this particular for the different so-called rare diseases. What is the way forward that you think that this should be used? Are we doing this at this stage, or is it still some time away to share this data with the public healthcare system in order to drive the budgets higher for healthcare?
Yeah, yeah, definitely. There's some very good suggestions, and I'm happy that you were a part of initiation of the registry. As I told that the registry took shape in 2019, but there was a lot of background work being done, and there were a lot of initial hiccups so that we could start actually entering data in the from last year in June only. So we actually started data entry from June 2022. And from June 2022 to today, we have 11,000 patients. And we are really now working on the improving the quality of the data. There was a lot of incompleteness of the forms, and you can see that there are only 21 centers reporting at present. So rather than going to the patient groups and the patients themselves to self-report to the registry, we would want more institutes to report to the registry who have their genetic diagnosis available with them, because the requirement of the registry at present is confirmed diagnosis with availability of genetic testing and or molecular testing in any way. Some disorders are not genetically tested. So at present, we are thinking of involving more institutions and more disorders to align ourselves with the National Rare Disease Policy. Maybe later on, we would, as the awareness increases among patients, and maybe we can think of training patient groups and all on filling up the forms. And but as of now, we are just hinging on the institutional data only.
Thank you so much, Dr. Shukla. We have a question from Dr. Arti Santanam.
Hi there. I actually want to touch upon that social media aspect of it, Shobha, which you mentioned. I think there is a tremendous amount of opportunity, and there's a reach that social media has that very few of us, and an engagement that is lacking when it comes to patient registries. And I'd rather have my social media algorithms pick up on my searches on ALS and provide me a link to a telehealth or a CDC run registry for me to go and investigate. It doesn't have to be the data gathering portal, but just for awareness sake and making sure that these registries are reaching the general population. I think there's still something there in what you're talking about in trying to bridge that gap by using social media. I'd rather get that than any of the political ads I'm getting right now. I'd rather get that, right? So I think there is some potential there as long as we have a something along the lines of a telehealth portal that they can go to that would direct them to their local entity that would actually verify the data before it gets uploaded into the registry.
Yeah, no, I think that's a great point. It could be the somewhat of a first line of access, right? So it doesn't have to be the data access portal or the data collection portal, like you're saying. I think there is also, if we think about where we are headed with AI, it's becoming sort of, the earlier versions of AI were all required experts and data scientists, etc. But now it's ubiquitous. All of us are using ChatGPT. All of us are using large language models, etc. So how do we leverage those kinds of platforms to speed up some of this research? It may not be confirmatory, but it can point us into where to shine the light. And then you go back and, derive more data sets and collect more data.
Hi. There's a lot that other rare disorders can learn from conditions like ALS and Duchenne's muscular dystrophy. I was told at an Every Life Foundation event that, if sickle cell wanted to know how to do surveys, and start gathering data from our community, go talk to Duchenne's And, in terms of ALS, the first time I heard about ALS was from Michael Zaslow back in the early 90s when he came public and said I was diagnosed. And, his fans watching, he was an actor from Guiding Light and watched the disease progress in him, and then ultimately found out when he passed away. And just to see how the organization has grown and the work that you're doing is amazing. I'm very encouraged. But I want to say to Sophia, thank you very much for sharing, your experience and helping organizations to, beginning to collect data in the right way. And, and was mentioned that, some data really is incredible in what we need to be collecting. But what I would like to know is the cost, because I know the registry that we're starting to do now, when I talked about it, it's like, how much do we need to budget? And the response I got wasn't how much. It was, well, this can be very expensive. And I says, okay, I'm going to give you a budget, but this is what we want. And then we want to, grow to all of the things we know we need to collect, but where can we start within a reasonable budget? And then talk about, adding to that. So when you started your registry, but you're a data professional, so it's a little bit different and you had people who can work with you. But for a CBO that doesn't have that technical expertise, what does it cost to start a registry?
So there are a lot of patient registry vendors that are out there, and they range in cost from free to, 100,000 or more. I will tell you that we're working with Quartz and it's absolutely free. Our registry didn't cost us anything. So they are funded by Sanford Research. It's a big healthcare system, and it's completely free for patient groups. What they provide is we can have 2 surveys, so that's a limitation. We can't have more than 2. But one of the surveys is a general survey that's the same for all rare diseases that are using this platform. It uses common data elements that are recommended by the NIH, and it's really excellent survey. And another one is a disease-specific survey that, like we create for our own disease, you would create for your own disease. And the data structure is very good. And I have looked into multiple platforms, including paid ones, free ones, expensive ones. The data structure is really excellent. You have access to all your data, and you can very easily use it right away and share insights with your community. So obviously it depends on what you're looking for. So we don't have clinical data there. We don't have doctors who are inputting data. If that's something that's very important to you, then that probably wouldn't work. But for us, we were looking for something. We were happy with a simple registry that would allow us to raise awareness and share insights and work with this data. And we've achieved so much out of this registry. We wanted it to be used to share clinical trial opportunities with patients. So for our purposes, this was good. So I'm happy to, if you want to connect with me after, I'm happy to help you. If you're considering different platforms, I'm happy to help you sort of consider pros and cons. I just wanted to address one point that was brought up about like patients entering their own data. It depends on the type of data. So for example, we are not asking in our registry for patients to enter their lab results or for enter their medication doses, because we know it would be really messy data where we could never ever verify, and it wouldn't be useful to us. So you have to think about what type of data, if it's patient reported, what are we asking, and how can we verify the quality of this data. So let's say if it's genetic mutation of a patient, we know it's very important, and we do get back to patients and we ask them if it's not clear from their response, we ask for that information. And so the way we designed our service, we have data that is acceptable, for patient-reported data. So that's something to think about.
If I could just quickly add to that. So all our surveys are at the 8th grade level. So we want to make sure that, and they're all validated to make sure they're easy to understand and so forth. There are no big words because we want patients to be able to go in there and put their information in there and so forth. Regarding cost, research is not cheap, unfortunately. So we came about, which I didn't mention in my talk, by a tremendous push from ALS patients and caregivers to have their own ALS registry back in the early 2000s. And that's when they pushed Congress So the premise behind that is I think your community has certainly a lot of power to say, hey, we want our own registry, because that's what happened with the ALS registry. There was a tremendous push. The ALS Association, which is based here in DC, came out and they said, hey, we want a registry, and Congress passed the ALS Registry Act. Our budget's about $10 million a year. It's been that way for many, many years now. We probably started off at maybe $500,000 and it kind of went up incrementally and so forth. The budget of the other groups I mentioned, I mean, obviously the NIH is probably $300 million or more just for ALS alone. I think DOD is about $40 or $60 million a year. So we're actually the smaller budget piece in that area right there. But certainly having resources to have you on registry is very important. And I think leveraging the community to go ahead and make sure their voices are heard is also very important as well. And going to the powers to be and simply saying, hey, we want a registry, and going from there. CDC has a number of registries. I'm not sure if there's a sickle cell registry at CDC or not. There are other registries. There is. Okay. It's probably under. Okay. Okay. Got it. Got it. Got it. Yeah. Yeah. So regarding data, all our data are available for researchers. So they can come to our website and they can go ahead and apply for the data, and they can get these data sets and data elements from us as well. And so they're all available. It's available for free. We just make sure the application submitted is efficacious and meritorious to make sure what someone's requesting is related to ALS research and so forth. But we do have our data and they're all available for researchers as well.
So, Ginger, I'm sorry.
It's all de-identified data. We never release any PII. That's where the consent form comes in. Your consent form has to say this is for research. Your data can be used and shared with other individuals or researchers for the express purpose of research. That's where your consent form comes in to go ahead and make sure that's fine.
A lot of sage advice. So thank you for those insights and great question. One very quick final question and before we close out.
Okay. Yeah. Hello, everyone. It was a wonderful session. I'm Mahua. I'm a policy researcher from Indian Institute of Science, and presently I'm doing my Masters of Public Health here in Johns Hopkins. It was a wonderful session. I have actually two questions, if I could just quickly put. One is to Dr. Shukla, as you mentioned that the rare disease registry is still in its inward form. I'd just like to know from you when it is going out in public and when the larger public can access it. What is the plan for it? And maybe quickly, I'll put the second question as well. It is about the global data sharing. As you mentioned, I would like to understand what is the cross-border data sharing policy restrictions that you face in terms of, as you mentioned, the data quality. Every country would be having, if we have to tap on the quality data, then every country will have their own restrictions regarding the de-identified data as well. Unless we go for the patient advocacy route directly, for which also I think there will be some guidance for the country-specific data sharing. So if you could share what are the challenges.
So our data are available to researchers around the globe, both our biospecimens and our data itself. There are no restrictions there. So they're all available. The data I mentioned, the restrictions were our funded partners, where if there's a research grant and they're getting data from the Europeans and they want it to come to the US, there could be problems there or some limitations and so forth. But all our data is to researchers across the globe as well, and domestically too.
Thank you all for the wonderful discussion today. Very, very insightful. I'm Dr. Isaac Rodriguez Chavez. I am a former FDA official, and a former executive and one of the largest clinical research organizations. So I have conducted many trials, including rare diseases. I remember in my time at the FDA, there was a guidance that we developed, and I wanted to bring your attention to that guidance because we're talking about globality of registries and the importance and the applications of registries. And so this is pertaining to the FDA and the United States as a part of the regulatory jurisdiction of the FDA, and that is connected to real world data assessing registries to support regulatory decision-making for drug and biologics products, for drugs and biological products. And this is a guidance that was published in November of 2021. So I hope that you all are paying attention to this as a lessons learned and as a guiding principle as to what kind of elements we should consider in setting up registries. So what happened is that the agency faced the plethora of registries that were collected in multiple shapes and forms. And then many organizations wanted to use that information for decision-making and for informing intervention and clinical research. So this was a way to guide the field as to the type of registries, the type of data to be collected, the considerations included to be considered in the registry, the purpose, the specific objective of the registry, the kind of design, the kind of data collection, and the methods that needs to be used for the specific registry to do things in a systematic form, the data quality checks, the ability to link the data to other sources. Is trying to harmonize and homogenize and indicate to the field the type of things that should be put in place when it comes to registries. So I hope that you consider this as a guiding principle. And this is a current thinking. It's not an imposition. It's a guidance. It's just to guide the field and trying to improve the content of the registries.
Can I
That's
just
a
quickly-
fantastic comment and insight. Thank you so much, Isaac, for sharing that with us. So I will give one last chance to all of you to answer that question, but also the final question for the panel, which is, when it comes to cross-border collaboration, the current relationships in terms of US and India, recently there has been a lot of exciting activity. Prime Minister Modi, visited US and addressed the House and Senate here, as well as FDA Commissioner recently visited India to assess the pharmacy of the world and its readiness for engaging on a greater scale. So with tomorrow, we have Dr. Peter Marks delivering a keynote address on his vision for the START program, which is the Operation Warp Speed for rare disease, on how we can accelerate and treat each rare disease as a global public health emergency and how we can accelerate that. So given all this exciting stuff, which is also going to engage rest of the world, including India, what's your, and one of the things that Prime Minister Modi said is AI is America, India, in addition to artificial intelligence. And so AI and US, India seem like a strategic synergy there. What's your vision or hope for US-India collaboration in tapping AI for data, registry, clinical trials from a rare disease point of view? You can also answer that question in your closing comments. Who wants to go first?
I really just wanted to answer the question about the FDA guidances, because I've actually read them. And it's very these guidances are all written for the industry. And it's so important to recognize that right now, most rare disease patient groups have registries that they're developing completely without an industry partner. They're doing it on their own. So these guidances are really needed for the patient groups. It's very sad that there's a lot of collected data by patient groups that ends up never being used by anybody. And it's so important. I mean, the reason that I started the working group that I talked about is actually because there are no guidances for patient groups. And I wanted to at least create something, some kind of guides. But FDA, it's so important. When we had our listening session with the FDA, I told them the same thing. I said, I'm happy to lead this effort. I'm happy to work with the FDA to start this working group or whatever they want to do with it so that we can create these guidances. I mean, it's just so critical. So critical, just given the situation that patient groups are all creating registries and collecting data.
Closing comment?
Yeah, as far as working between US and India, I mean, our foundation, we are very happy to be a part of Indo US Rare. We hope to continue and do a lot more together. We are really trying to get more patients from India into our registry. We only have a few, but hopefully now that I'm here, there will be a lot more. And yeah, really looking forward to more collaboration.
I guess my closing comment is 3 cheers to America, India, AI. I think we now really have the tools and innovation, at least, that are starting to explore and address some of these challenges. We won't have a chance to get into all the details, but I would urge everyone to, if we really want to push this forward in warp speed, we cannot continue to do stuff the way we have always done, right? So just centralizing data, why are we centralizing data? There is this new innovation called federated learning, right? So let the data sit behind the firewall of every institution. You can simply have AI go and crawl and draw the insights and merge the insights like that, right? I mean, it's not that trivial. Of course, devil is in the details, but these tools and innovations are emerging. So if we really want to do things in warp speed, my plea to this fantastic community is let's approach it with humility, but at the same time, start to think about how we apply these innovations to start doing things differently.
Just to quickly answer your question, we actually were, we provided some guidance to the FDA document when that first came out. CDC is a sister agency of Health and Human Services, which is a part of the FDA as well, which sits within Health and Human Services. So we actually provided guidance on the FDA document to utilize registries and the power of registries. We have actually helped to recruit dozens of clinical trials throughout the since for the past 8 years since we had this program and so forth. But just going back to AI, I think AI is important, but it can't be the end all be all. I think you don't want an AI doctor diagnosing you. You want someone who's going to be diagnosing you and taking your signs, your symptoms and so forth and making the assessment, the differential and so forth. I think AI is important, but I think it also must be utilized very carefully as well because it's prone to mistakes and so forth. And whatever you put in, whatever the output is, it's based upon what you put in. So if it's bad data, you may get bad results. So I think it's very important to take AI with a grain of salt. Back to India and U.S. relations. I came to India. I came to the U.S. when I was 5 years old. So I speak Hindi and Punjabi still. I can still speak my mother tongues. But the premise is, I think it's really, really important to have cross collaboration among continents, among countries, because there's expertise which lies in India, which also lies here as well. And I think that certainly can be utilized and flexed to make, whether it's registries or whether it's patient care or whether it's treatments, come to fruition by having this cross collaboration between scientists and clinicians across both countries.
Dr. Shukla.
Yeah, it was really enlightening to be here and get perspective on what we are doing from the American point of view and where we stand. And I really hope that we are able to learn more and continue this way and turn the baby steps into strong strides. Thanks a lot.
Thank you so much. Please help me thank the fantastic speakers. So before we break now, I request all of you to hold a souvenir for a photo